we should know is like cardiovascular disease remains a leading cause of morbidity and mortality worldwide. And over the past few decades, clinical research has played a crucial role in developing safer and most effective therapies, like from new drugs and stents to minimally invasive procedures. So, today we will explore how carefully designed clinical trials drive innovations in cardiology, which has also ensured the patient safety and translated the scientific discoveries into uh, real world treatments. So, before getting into the actual topic, let me start with a small activity. I just want you people to raise your hand in the Zoom meeting app itself. If you have someone in your family with high blood pressure, diabetes, or heart problem, you can just raise your hand in the Zoom meeting itself. If someone in your family have IBP, diabetes, or heart problem. Hmm. Yes, it's like almost all of us. So that's the reality now. Cardiovascular disease is not just something written in textbooks. It's like it's around us, in our homes, in our WhatsApp family group, even in the morning newspaper. Now, there is some important thing I want you to remember. Like, even single treatment we use in cardiology today exists only because of clinical research. You can think like that amlodipine tablet that your grandmother takes for blood pressure at the morning. It was once tested in a clinical trial, and the stent that saved your uncle's life during a heart attack. It became possible only after years of clinical studies proving safety and effectiveness. And even the smartwatch that can detect atrial fibrillation, even that too had been undergone research, validation, and approval before we could wear it in our wrist. So, what does this mean? It means like clinical research is the backbone of cardiovascular disease. So, without research, we could still be guessing treatments. And with research, we have evidence based therapies from lifestyle changes to drugs to surgical interventions and even to the devices that we use. And that's exactly our theme today. So, we are going to look at cardiovascular therapeutic interventions, but not just as a doctor's prescribing treatment. We will see them like through the lens of clinical research, like how these therapies came into practice and how trials shape them and how future research will transform them even more. So, let's go slightly deeper into the topic, the foundation. When we talk about cardiovascular disease, we should remember that we are talking about the number one killer worldwide. More people die of heart attacks and strokes every year than from cancer, infections, or accidents combined. But mm, my question to you is like, how do we even know who is at risk? For this, we usually divide these risk factors into two buckets. One is of non modifiable risk factor, and these are the things you can't change, like your age. The older you get, the stiffer your arteries become, and your sex. So men are more means like men often develop heart disease earlier compared to the women who can catch up after their menopause phase. And of your genetics. So family history. If your father had a heart attack at 50, you own a risk which may come up even earlier as well. And second is of modifiable risk factor. So these are the one that ones can even change, like smoking, which damages the endothelium of your vessel, and high cholesterol, hypertension, obesity, diabetes, lack of exercise, and yes, even the stress and poor diet as well. And if you just think about these, none of this was common sense 70 years ago. Doctors in the early 20th century didn't even know, like, cholesterol or high blood pressure had everything to do with the heart disease. So, for this, to understand what was the history and how it helped us with the lifestyle, pharmacological intervention, advances in surgical intervention, I have categorized them into five agendas of today. So, we will go one by one. So, as I said you before, we are going to enter into the history of the foundation. And this is where the clinical research changed the game. At that time, there was a study that completely changed the way we look at the heart disease. That is the Framingham heart study. So it started in 1948 in a small town called Framingham in Massachusetts, USA. The US government wanted to understand why heart attacks were increasing rapidly, especially after the World War II. So they invited ordinary residents of the town to participate, over 5,200 men and women. And what did they do at that time was simple, but they just followed the people years after year. They measured their blood pressure, cholesterol level, smoking habits, weight, diet, and even the exercise pattern that they do. And they recorded their health outcomes, like who developed heart diseases, who had stroke, who stayed healthy. Then in 1948, terms like high cholesterol or hypertension were not considered dangerous. People thought like it's a kind of little shout and she's just a bit stressed. And no one imagined like these could cause heart problems. But after years of observation, a pattern started to emerge. People with high blood pressure were getting more at heart attack, and people with high cholesterol had more blocked arteries, and smokers had higher risk of sudden death, and those with obesity or diabetes were in serious danger. This was the first time the world realized that certain conditions and habits directly increase the chance of heart disease. And that's when medicines borrowed a new term called risk factor. And yes, this very first phrase of terming as a risk factor came from this Framingham study only. So today, when a doctor says like, please stop smoking, control your cholesterol, check your blood pressure regularly, it's not because they just feel like nagging you. It's because decade of clinical research proved these are deadly. Means like these are the deadly risk factors. So just think about it. Without the research, we would still be in the dark. We will still be treating only the chest pain when it happens and not preventing the disease before it strikes. And the Framingham study also taught us something profound, like prevention is powerful. It showed that lifestyle modifications like exercise, balanced diet, quitting tobacco are not just nice advice. It's like something scientifically proven strategies to save the life. And over time, this research shaped global guidelines. The reason why the WHO, the American Heart Association, or even your local physician insist on yearly BP check, lipid profile, and diabetes screening, it's all because of the research we underwent earlier. And here's the another point I can add upon this, like the study is still going on. Today, it's tracking the third generation of families in the Framingham. Like, imagine grandparents, children, and now grandchildren, all contributing to the science. So, we now know there is a link between heart disease and genetics, inflammations, and even psychosocial stress. So, let me ask you one question. How many of you thought stress was just an excuse people give for chest pain? So, actually, the Framingham study proved that chronic stress, specifically job related stress, increases the risk of heart disease. And that's how deep the impact was from the study. And so, next time if you hear someone says, like, oh, my father smoked all his life and nothing happened, you just know the truth. Research doesn't work on individual people, it works on patterns in thousands of life. So, without such studies, medicines would still be reactive, like treating only after the heart attack. So, now let's move into the lifestyle and prevention. And before getting into this, let me start with a simple line. The cheapest medicine for the heart is still walking daily. It sounds like something your grandfather could say while sipping a tea. But in modern medicine, we don't just take it as a wisdom, we just test it. And that's the beauty of clinical research. So, for this, I just want to give an example of a trial which was done using a food as a therapy. So, back in the 1990s, researchers asked a bold question like, can food alone treat high blood pressure? For this, they designed like what we are using at present, the famous DASH diet. So, which stands for dietary approach to stop hypertension. So, instead of handling out new drugs, they took a group of patients with high blood pressure and did something very simple. They just changed their diet, like the salt was cut down, fruits and vegetables were increased, low fat dietary was added, fried and fatty foods were reduced. And now we will expect some improvement. But the results were shocked even after the means like even the researchers got shocked with the results. Patients who followed this diet saw a significant drop in blood pressure without swallowing a single pill. For the first time, science had proved that many suspected, like food is not just fuel, it can be a therapy as well. So the next time, if a doctor says, like, eat less salt, you can remember that it's not a random advice or something that your grandma's household tip. It is like a trial proven evidence backed up with the clinical research. And there was another study. Uh, okay, I didn't mention that here, it seems. Okay, it was of Interheart study where they were comparing lifestyle with genetics. This was not just any trial. It was one of the largest global study ever, spanning 52 countries. So where they were researchers were comparing two groups, uh, people who had suffered with heart attack and people of the same age and background who did not have the heart attack. And what they found was like a kind of eye opening. The biggest risk factor were not your genes. It was not just like family history. The real culprit was smoking, obesity, physical inactivity, and poor diet. And yes, actually, this genetic did play a role, but lifestyle factors were far more powerful in causing heart disease across the globe. And this single study changed the way we look to how to prevent this. It proved that no matter means like no matter where you born, whether in India, Africa, Europe, or anywhere, the way you live matters more than the DNA you carry. So if we compare this DASH trial with intra study, DASH trial was proven that diet can directly lower your blood pressure by reducing the cardiovascular risk without the drug. And on other side, the intra study showed that globally, lifestyle factors like smoking, diet, and obesity matters more than the genes. So now only I'm coming to this particular side. So if you ask like what was the lesson from these studies is like because as future researchers and healthcare professionals, you need to understand that even the simplest of medical advice, like walk 30 minutes a day or cut down smoking, is evidence based medicine. It is not about scaring patients or giving motivational lectures. It is about decades of solid clinical research. So now let's shift to the prevention to treatment. I can means like I like to call them as the soldiers of heart care. So these are the drugs that march into the march to fight the high blood pressure, prevent clot, and keep the cholesterol under control. But the real question is, how do we know which soldier is truly strong, reliable, and safe for the patient? The answer again lies here is clinical research. Every pill in that little silver strip is there because a trial proven it deserves a place in a doctor's prescription pack. So let's take it one by one. There were few more studies that proves how pharmacological intervention under cardiology got shaped because of clinical research. So the first one is of Hull trial in 2002. So hypertension or high blood pressure is called the silent killer. It slowly damages arteries, strains the heart, and leads to stroke as well. So for decades, we had many medicines like diuretics, AC inhibitors, calcium channel blockers, and they were newer agents as well. But the million-dollar question was, which one is the best first-line drug? And that's where this Hull had trial, the antihypertensive and lipid-lowering treatment to prevent heart attack trial, the actual full form. Antihypertensive and lipid-lowering treatment to prevent heart attack trial was coming in. So it was conducted in the US and Canada. It enrolled more than 42,000 patients, one of the largest blood pressure trial in history. The study was comparing different classes of antihypertensives like thiazide diuretics, which we also call as the water pills, AC inhibitors, calcium channel blockers, and alpha blockers. And the results were like surprisingly simple. The thiazide diuretics, the oldest and the cheapest drug, perform well, uh, but it's like if not better than the newer expensive medicines in the preventing heart attack, stroke, and heart failure. So, what was the lesson that we can learn from this is like sometimes the humble old drug sitting in a government pharmacy shelf, just as well as a costly brand new pill, can be recommended as a first line therapy. So, when you see a doctor prescribing hydrochlorothiazide instead of some fancy new molecule, it's not just because they are outdated. It's because Hull had proved that even cheaper drug can also be the best one. So now let's move to the completely different battlefield. The patient who had, who means like who just had a heart attack. It's like every second matter for them, right? So we now know like clot formation blocks blood supply. But the question in 1980s was, could simple drug reduce the death after a heart attack? And that's where this ISIS-2 trial was coming into, which we call it as second international study of infarct survival. And this changed the complete game. This trial, run in the UK, enrolled 17,000 patients with acute myocardial infarction. It tested two simple interventions. One is of the aspirin, the cheaper painkiller, where everyone had in their home, and second is of streptokinase, a clot busting drug. And the results were kind of revolutionary. The aspirin alone reduced mortality by 23%, and streptokinase alone reduced it by a similar margin. And when combined, they worked even better. So before this trial, aspirin wasn't taken seriously as a heart drug. But after ISIS-2, aspirin became a gold standard of care. And even today, millions of people who have had heart attack or stroke pop a small white aspirin tablet daily. And this small tablet owe their lives to this one trial. So you can just think like even sometime a cheap as aspirin, which is costing less than a cup of tea, becomes a life-saving therapy because of the strong clinical evidence. And later there were more trials brought in like for clopidogrel, ticagrel, and DOACs. But the story begin with the aspirin. So we have covered like how the diuretics has become the first line of drug treatment and how aspirin came into the therapeutic intervention. And now let us move on to the another factor. Let's talk about cholesterol. It's like a sticky villain of heart disease, right? So for decades, we know high cholesterol was bad, but doctors were debated. If you lower it with drug, does it really save lives or just make a lab report looks better? So this debate ended with a 4S trial. So it the actual full form of it is like Scandinavian simvastatin survival study. That is why it was coming with 4S. That is why we term the study as 4S trial. And it was conducted in 4,444 patients with high cholesterol and coronary heart disease. It was the first major randomized trial testing a statin, that is the simvastatin versus a placebo. So you people are aware of what is placebo, right? Can anyone say that? You can just respond in the comment section. I just said this forest trial as compared simvastatin with the placebo, right? So what is this placebo is about? Dosage without API. Okay, no API. So there won't be any active pharmaceutical ingredient in the inherited therapeutic effect. So there will be no active pharmaceutical ingredient in the dosage form, which has no inherent therapeutic effect. It is like just checking how the drug psychologically affects the patient instead of therapeutically. So even in this study, they were using placebo, and the results were shocking the medical world. Over 5 years, simvastatin reduced overall mortality by 30% and cut the death from coronary artery disease by 42%. This was not just about lowering the numbers on the lab test, it was about saving real lives. The 4 years trial also proved that statin doesn't just control the cholesterol, it also prevented the heart attack and prolonged the survival of the patient. And from then on, the statin become the backbone of cardiovascular prevention. It is a kind of small white pill which you can see in your father's pill box, like atorvastatin, rosuvastatin, or simvastatin, which is not just a prescription. It is the child of a massive global clinical trial that forever changed the cardiology. So, no cardiovascular drug is prescribed casually. Behind every pill is a massive randomized control trial. And behind every white tablet, there lies thousands of patients who volunteered, like with years of follow and mountains of data. So clinical research doesn't just invest new drugs; it also decides like which one becomes the standard of care as well. So as of now, we have covered the first three agenda of my session, and so far we have seen how medicines change the landscape of art care. But what happens when tablets are not just enough? And that's where the technology steps in. Surgery and devices could have been equally shaped, not just by innovations in operation theaters, but by rigorous clinical trial. So the last one which I'm going to discuss under this surgical interventions and the devices that we can use will be somehow which you would have not been expected under my session. So just listen to my session carefully, guys. So under advanced surgical interventions, I will start up with the angioplasty and stents. So when balloon angioplasty was first introduced in 1977, it looked like a magic. A balloon goes into a blocked artery, opens it up, and restores blood flow. But soon, doctor began asking like, does putting in a stent actually saves life better than the medicine alone? And that's where this courage trial in 2007 stepped in. It was a landmark study that enrolled over 2,200 patients with stable coronary artery disease. Patients were divided into two groups. One got the optional medical therapy, like blood thinner, cholesterol lowering drugs, lifestyle advices, and the other group got medical therapy along with the angioplasty with stents. And surprisingly, after years of follow up, the results showed no significant difference in death rates or heart attack risk between the two groups. So, in simple words, stent did not prevent the heart attack better than the medicines in stable patients. So, what stent did it was relieving the chest pain faster than the medicine. But the story doesn't end up here. The researchers felt like courage was missing means this courage trial was missing a key piece, like how do we decide which blockage truly needs a stent? And that's where this FAME2 study, FAME2 study in 2012 came in. So instead of just looking at the size of a blockage, this trial used a technique called fractional flow reserve, which we term as FFR, fractional flow reserve, basically a pressure measurement inside the artery to see if the blockage was really limiting the blood flow. And this FAME2 showed that stenting only the blockage proven to reduce the blood flow, which actually led to a fewer hospitalization, and there were fewer major cardiac events compared to the medicines alone. And this shifted the practice like stents are most useful when we can prove that the blockage is causing real ischemia. So now let's move on to the surgery, the famous CABG, coronary artery bypass graft. And for decades, there's been a debate like should a patient get stent, that is the PCI, or bypass surgery. So multiple large trials have looked at this. One of the most important one was Syntax 2009. And this study included like patient with complex coronary artery disease. It found that patients with simpler disease could do equally well with the stent, but those with multiple blockages or uh, like left main diseases had better survival and fewer repeat procedures with CABG. And then came this freedom trial, which was conducted in 2012, focusing on diabetic patients with multivessel disease. And this trial proved that for diabetes, CABG surgery was superior to stents. It also reduced heart attacks and deaths. And this completely changed the guidelines. And now, diabetes with widespread diseases are often referred to bypass surgery instead of PCA. So we can say like research clarified that it's not one size fit to all. Some people benefit from means like some people benefit more from stent while others live longer with surgery. And the next one is of pacemaker and implantable defibrillators. So this will sound like pure engineering brilliance, but their place in practice was only confirmed by clinical trial. So one of the most famous is the MADIT 2 trial, which was conducted in 2002. This trial looked at patients who had already survived a heart attack and had weak heart function. So normally these patients were at risk of sudden cardiac death due to dangerous arrhythmias. And this MADIT 2 tested whether implanting an ICD could save lives compared to the medicine alone. And the results were like dramatic. Patients with ICD had a 31% reduction in death compared to the medical therapy. And this cemented ICD as a life saving device, not just as a technological luxury. And for pacemaker trial, means for the pacemaker, they had another trial like companion trial and CARE HF trial, which were conducted in 2004 and 5, showed that special types of pacemakers like biventricular pacemaker used in cardiac resynchronization therapy could improve the survival and reduce the hospitalization in patients with advanced heart failure. And now let's talk about the heart transplant and cyclosporin trials. When Dr. Christian Barnard performed the first heart transplant in 1967, it made headlines worldwide. But unfortunately, most patients died within weeks or months because of their immune system rejection with the new heart. The turning point came into the in 1980s with the clinical trial of cyclosporin. It is like a revolutionary immunosuppressant. So, yearly studies showed that patients receiving cyclosporin after transplant had dramatically better survival. Like 1 year survival rate jumped from around 30% to nearly 70%. And this transformed heart transplantation from an experimental short lived attempt into a standard and reliable therapy for end stage heart failure. So, the takeaway for the previous agenda is like every surgical advances and devices you see. I got a call in between. Can you hear me, guys?
Yes, sir. Now you're audible.
Okay. So every surgical advances and devices you see in hospital today, whether it's a stent, a bypass, a pacemaker, or even an heart transplant, becomes standard practice only after rigorous clinical trial, proven with their benefits. And now let's talk about the future therapies. So when we talk about the future of cardiology, it sounds almost like science fiction. But the truth is, many of these ideas are already being tested in clinical trials today. So I just want to explore a few examples, of which the last one will be much interesting for you. So first one is of stem cell therapy. So just imagine if instead of living with permanent damage after a heart attack, we could simply grow back healthy heart muscles. One of the biggest dream in cardiology is to heal a damaged heart. Unlike the liver or skin, the heart has very little natural ability to regenerate, like once after the muscle cell dies. So clinical researchers began asking like, can we grow new heart muscles using the stem cell? Mm, so for this, there was a trial that underwent. I didn't mention that in the slide. It seems there was a trial called Repair AMI trial, which was conducted in 2006. Was one of the first largest study in this area. So researchers injected patients with their own bone marrow stem cell after a heart attack. The results showed that like modest, but there was no real improvement in heart pumping function, which we also term as LVEF, left ventricular ejection fraction. But later, the studies like BAMI, the actual full form will be like bone marrow derived mononuclear cell for acute myocardial infarction. They tried to scale this up, like even their results were somehow mixed. But these trials are teaching us like who might benefit, what type of stem cell could work best, and how to deliver them safely. And second is of gene therapy. So some heart problems are literally like written in the genes, where patients are born with the faulty genes that causes dangerous lipid disorders. So there were few dangerous lipid disorders, right? Like uh, familial hypercholesterolemia or structural heart problems like inherited cardiomyopathies. So instead of lifelong pills, they were thinking like, could we fix the gene itself? So traditionally, drugs can only do few, but clinical research in gene therapy is testing ways to actually fix the gene itself. So there was a trial in 2010 for this, which was Cupid trial, which was testing gene therapy called AABI for advanced heart failure. So the concept was like to deliver a healthy copy of a calcium handling gene directly into the heart muscle. So early results were exciting here, like showing improved heart function, but later larger trial didn't meet the endpoints. So still the research were opening the door for new generation gene therapies like CRISPR, which is something based on editing the gene, which are now entering the first in human studies. Next one is of artificial hearts and bioengineered valves. So for decades, mechanical devices has been used as a bridge until patient could receive a transplant. But clinical research is now testing like whether fully artificial heart can be a destination therapy. So there was a company called SYNCARDIA, which has total artificial heart, went through the pivotal clinical trial that demonstrated like it could keep patients alive for months to years while awaiting for transplant. And more recently, there was another trial which we call as CARMAT trial, which was conducted in Europe at 2013. Tested means it is still ongoing. It was started by 2013 and tested a fully implantable artificial heart designed to mimic the natural blood flow. Under those studies, the early patients were facing complications, and the trial proved that it is possible for a machine to take over the work of the human heart for months or even a year. And similarly, there is another recent one which even I am working under, like transcatheter valve, which we call as TAVR, underwent a rigorous trial, like partner trial in 2010, showed like TAVR was life changing in patients who couldn't undergo open surgery, and it has changed the practice worldwide. And the next one is like the gadgets. So now let's move on to the most interesting part of my session today. It's like something that touches almost everyone's daily life, the wearables. So think about it like smartwatches, fitness trackers, even apps on your phone. Most of us already like we already use them to count our steps, check our heart rate, and remind us to stand up, and even they track our menopause, right? But in the world of clinical research, these gadgets are become powerful medical tools. So one of the landmark studies that changed the game was the Apple Heart study. Yes, it is the actual Apple study done with the Apple Watch. So this wasn't a small traditional trial run at a single hospital. It was one of the largest virtual clinical trial ever conducted, with more than 4 lakh participants enrolled. And the best part is people didn't have to visit clinic or hospitals to join. All they needed was a Apple Watch and an iPhone. That's it. So if you ask like what they did at the time of study, the goal was to see if the Apple Watch could reliably detect atrial fibrillation. Yes, it is of something related to the atrial fibrillation. And for those of you who may not know, like what is AFIB, I can say like it is an irregular heart rhythm that increases the risk of stroke, even the heart failure or other complications. So often patients don't even know like they have it until something serious happens. So the Apple Watch uses special sensor to monitor the pulse and rhythm. If it detects something unusual, it will notify the user. And participants who got an alert were then guided to follow up with a telemedicine consultant and even wear a ECG patch for more detailed monitoring. And the results were like the study showed that the watch was remarkably accurate in detecting atrial fibrillation and directing users to seek timely medical attention. If you ask like why this is important, because it represents a shift in clinical research and healthcare delivery. So traditionally, like detecting atrial fibrillation requires like you should come to the hospital, you should get hooked up with the machine and undergo the test. But now your wristwatch can warn you like while you're sitting in your living room, at your office desk, or even while you're sleeping. So screening is no longer limited to the hospital. It also moved on to your homes as well. And it doesn't stop here. Clinical trials are now exploring how wearables and digital health tool can help in many other areas as well, like the heart failure management. Imagine a smartwatch that not only tracks your heart rate but also detects minor changes in your activity, like breathing or even your fluid buildup. So actually, ongoing trials are testing whether this continuous monitoring can predict worsening heart failure before the symptoms even start, just to allow the doctors to intervene the condition earlier. And these wearables also help in hypertension control by monitoring the blood pressure. It also studies round the clock monitoring gives a more accurate picture than occasional clinical reading. So instead of just knowing your blood pressure during a 5-minute doctor visit, physician could have access to the thousand of real-time data points showing like how your blood pressure behaves throughout the day, during the stress, or even while you sleep. And finally, there is another one that rules the medical world, the artificial intelligence. And this is where the things get really futuristic. AI algorithms are being tested alongside of wearable to analyze the massive amount of patient data in real time. The goal is to move from reactive medicine to treating disease after it appears to predictive and preventive medicine, where your device could alert your days or weeks before the clinical means like the medical crisis occur. So the big picture is here, whether it's stem cell, gene editing, artificial heart, or even your smartwatch, none of this innovation enters clinical practice without passing through the rigorous trial. The future of cardiology is uh, unfolding inside clinical labs and study centers right now. So let me close with some motivation. So just imagine like a human heart beats around 1 lakh times a day. Think about that for a moment, like 1 lakh tiny rhythms carrying oxygen, energy, and life through a body without a pass. That's not just biology. That's like 1 lakh chances to live, to love, to love, even to dream, or to make every single day meaningful. But here is the truth, like those speed don't happen in isolation. They are protected, strengthened by decades of science. And clinical research is the quiet guardian behind every beat. It ensures that the medicine you take are safe, that the stent placed in arteries work as they should, and that innovations like the innovations like digital wearables are not just gadgets, they are like life-saving tools. So the next time, if you feel your heart racing with excitement, slowing with peace, or simply beating steadily in the background, you should know that behind the rhythm is the work of countless researchers, doctors, patients who dare to ask, like, how can we make the next beat safer than the last? And that's the promise of clinical research. And that's why every heartbeat is not just a pulse of life, it's a pulse of science here. So, thank you guys. That's the end of my session.
Thank you so much, sir. If participants have any questions or queries, they can put in the chat box.
I guess no one have any question.
Yes, sir. Thank you so much, Dr. Anand Deepak, for your inspiring presentation. Your vast experience in clinical pharmacy education, patient centered care, and research innovation has given us a deeper understanding of how pharmacy professionals can transform future therapies in healthcare practice. We are grateful for your presence and for sharing your expertise with us today. Thank you so much, sir.
Thank you. Thank you, team.
On behalf of SYCCON S6, I sincerely thank you, our esteemed speakers, Dr. Jerish Ashwin and Dr. Anand Deepak, for their enlightening talk. Your expertise has not only broadened our understanding but also inspired us to look at healthcare from new perspectives, whether it is the innovative functional uses of Botox in ENT or the expanding role of clinical pharmacy in patient centered care. I also extend heartfelt gratitude to all participants for your active presence and engagement. Together, we make such knowledge sharing platforms meaningful. Thank you once again, and we look forward to day 19 of SYCCON for more such enriching sessions. Thank you. The feedback form has been sent in the chat box. Make sure you fill the form.
We are done for the day, guys. You can leave the meeting.